Hi everyone, just as everybody's coming in to get seated, if I can just remind you all to have your Slido app, and if you remember to change to Affiliation Hub 1 and 2 if you've got any questions and answers to be putting them through as Gordon is presenting. So just to get us started in the interest of time, I just want to introduce Gordon Wishart from Check4Cancer. Hand over.
Thank you very much. Can everybody hear me okay? Good afternoon. We're here today to talk about how you would approach really setting up a cancer prevention strategy. And as I'm giving this talk, if you think about cancer prevention, not just preventing cancer actually happening, but actually prevent it advancing. How can you pick it up early? So this is really all about prevention and early cancer detection. So we always have to start with some statistics, and so we have a big number of new cases of cancer every year in the UK, about 375,000. And as you can see in this graph on the right in red, that's predicted to rise to over 500,000 by the year 2040, which will soon be upon us. And if we look at the number of deaths, it's going to increase from about 175,000, which is about 400 a day at the moment, to over 200,000. So we have a big issue to deal with. And as we'll hear as I go through this talk, we actually don't have an infrastructure to manage this. We haven't kept pace with this rising cancer incidence. Now, one of the things I want you to take away is that for anybody born since 1960, you have a 50% chance of being diagnosed with one or other cancer in your lifetime. 1 in 2 chance. But I think an even stronger message to take home is that we now know many of the lifestyle risk factors that drive cancer incidence. And because of that, and because there's the ability to reduce your risk, we think about 40% of cancers are preventable. So that's something that's worth pursuing. But cancer isn't just a disease of the elderly now. So in the last 3 decades, there's been about an 80% increase in cancers being diagnosed under the age of 50, so-called early onset cancer. And it's been most prevalent in countries that are westernized or have recently become westernized. So it's certainly related to lifestyle and to many of the risk factors that feed into that lifestyle. So some of these listed here: alcohol, tobacco smoking, low physical activity, diets that are high in salt or red meat, and high fasting blood glucose. So people with uncontrolled diabetes are at increased cancer risk. We haven't seen that same incidence rise in the UK. It's about 30% increase, but it's certainly something that we're seeing. And I've talked to lots of people who are seeing more and more younger men and women with bowel cancer, often at quite an advanced stage. Now, one of the sad things is that as a developed country and having really helped develop many of the big improvements in cancer diagnosis and treatment over the last 20 or 30 years, we have the worst cancer survival in the G7. We're that yellow bar towards the left of this graph. So there are only 8 countries in the OECD countries that have a worse cancer mortality than us. The G7 is all the blue bars. So you can see we're quite an outlier. And there are several reasons for this. Now, anytime I mention these kind of data, I get a reply from the NHS to say, but cancer survival has improved over the last few years. So here's several different cancers: lung cancer, bowel cancer, cervical cancer, breast cancer. We're that kind of purple, thick band at the bottom. So yes, cancer survival has improved for most common cancers over the last 20 to 25 years. But it has for all the other countries as well. And we are still falling well short of comparable developed countries. Now, the key metric when we're looking at how can we improve that survival is early cancer detection. What proportion of cancers do we diagnose at stage 1 or 2 when it's still very treatable and curable? And as we can see on the left, in 2021, it was 54%. In 2023, it was 59%. Now, when we still had a national cancer plan 2 years ago, the aim was to get that up to 75% by the year 2028, 3 years' time, we're at 59%. We'll be lucky if we get over 60% by then. Now, we're quite good at detecting some cancers early. Things like skin and breast, you can see they're largely green at the bottom, so the majority of these cancers are diagnosed at an early stage. But go to the top and look at the big purple graphs. We're very bad at picking up lung cancer, pancreatic cancer, and even bowel cancer. We only pick up about 50% at an early stage. So we've got big challenges in trying to improve survival in this country, but the key is to detecting it early. So why have we got such a poor cancer survival? So this is the number of CT scanners and MRI scanners per million population in comparable countries. We're right at the right-hand side here. We have got the least. Most of Europe has 2 or 3 times the number of scanners we do. Japan has 10 times. It's the one right at the left. So, as I said, we just don't have the infrastructure to keep up, both with cancer diagnosis and treatment, because we're increasingly using CT scanners, not just and MRI scanners, not just to diagnose cancer, but to actually deliver treatment. You know, most radiotherapy now is guided radiotherapy. So that's a big issue, and that will cost a lot of money to put right. The other thing is that we have pretty much the least doctors and nurses per head of population. It's anathema to most doctors to understand why the government restricted places at medical school for the last 30 years. Yes, it costs a lot of money, but we're now in a situation where we just don't have enough doctors, but we also don't have enough nurses. And a lot of the nurses that had gone through advanced training are now replacing what used to be the junior doctors. So there's a huge, huge issue in trying to get doctors and nurses. And that's why we're trying to recruit doctors and nurses from overseas. We've always done that, but they're less likely to come here now. And actually, our doctors that are just qualifying are more likely to go abroad now. So huge problems with workforce. But is it all about early cancer detection? So when I was still in Cambridge in 2009, we did some work looking at why was the breast cancer survival worse than the rest of Europe. So we've always known that Scandinavia had really good breast cancer survival, and you can see even back then, Sweden, Finland and Norway on the left, you know, mid to high 80%. We thought we were doing quite good in the east of England at 83%, but when you break it down and you look at survival by age, which is this table on the right, you can see we do quite well for 45 to 54, 55 to 64, even up to 74, but after that it falls off a cliff. And I still think there's an ageist discrimination about the way that the elderly are treated in this country, and that they don't get the best treatment for their physical state. They're getting what the doctor thinks is the best treatment for their age, but actually 75 is the new 65, and I think this is still an issue. You know, we published this way back then, and we're still trying to resolve how to deal with that. So it's not all about early detection, it's all about who chooses your treatment as well. So let's get on to cancer prevention. How do we do it? Education plays a big part in this, not just about risk factors, and we'll look at some of those in a minute, but also the signs and symptoms of cancer, because we want people to come and get checked quickly if they feel that they have something that has changed, and there are different ways that we can do that. Risk assessment for cancer is becoming increasingly important, and the reason I say that is that most screening programs for cancer are based on age. So for instance, you're eligible for breast screening in the UK at age 50, everybody is. And that's because we assume that most people will have reached a certain risk threshold at that age. But lots of people will reach that risk at a much earlier age, not just for breast, but for all cancers. And we need to start moving away from age-based screening to risk-based screening. We know the risk factors. It's quite easy to work out who should be starting cancer screening at a certain age. So this combination of education, risk assessment and cancer screening is really the holy grail in terms of trying to deliver cancer prevention. Now, we've done education in lots of different ways. We've used infographics, but people want information in lots of different ways now, and we need to catch up with that with, short podcasts, with short videos, with lots of different ways of getting that message across, both for the signs and symptoms and about risk factors. So here's a summary of the risk factors that we know at present. So everybody knows smoking is associated with lung cancer, but it's also associated with bowel and cervical cancer. Alcohol is part of the reason that breast and bowel cancer incidence is going up. And obesity is driving bowel cancer risk, and it also increases postmenopausal breast cancer risk, not so much in premenopausal. And if you look at the column on the right-hand side, these are the percentages of those cancers that are preventable. So in bowel, about half of all bowel cancer cases are preventable, and about a quarter of breast cancer, and the vast majority of skin cancer and lung cancer. So there are lots of things that we can do. So what about corporate cancer screening? We've seen a huge surge in corporate cancer screening post-COVID as employers step in. Really, I think it started with being uncertain about what state the NHS was going to be in, but really just a general way of looking after your employees. So screening doesn't just pick up cancers early, it actually picks up a lot of high-risk lesions that would have developed into cancer had they not been removed. So screening does two things. It detects cancer early and it stops cancer developing. You can do risk-stratified screening. We have a questionnaire now that looks at cancer risk for up to 6 different cancers, so that companies that have a large number of employees can focus their spend on those at highest risk. So everybody gets education, but you target screening to those at highest risk. And we now have tools that we can use to work out what is the return on investment if you invest in screening now. What's the return over the next 5 to 10 years? So why are we so interested in detecting cancer early? Looking at it from a patient perspective, it means the cancer is less likely to have spread. That means less invasive treatment is required, less time off work, less time away from family, better survival rates, maybe more importantly, better quality of life. So that's a no-brainer. And those are benefits you can see straight away when you start picking up cancer early. If we look at it from an employer perspective, less workplace absence, less treatment side effects, less presenteeism, reduced disruption from key employees, and that can be a big issue, especially in smaller companies, but also reduced treatment costs, less death in service benefits. And as I'll show you, we can feed all of these into a return investment calculator to work out what those real advantages would be. Corporate cancer screening remains probably still the most sought after employee benefit. And certainly in kind of year after year reviews from Mercer Marsh Benefits, we see it coming out top across all age groups. Screening can be delivered either as a flexible benefit, which I thought a few years ago was just going to die away when the tax advantages were removed, and it just gets busier and busier. But it's still a number of companies who've perhaps seen a number of a specific type of cancer happen over the last 1 or 2 years, still think about doing bespoke campaigns where we go in and actually just screen for one particular cancer across the whole workforce. So there are lots of ways that you can deliver it. Risk-stratified screening, as I alluded to earlier, is where you base screening based on personal risk rather than age. And there's good published evidence to show that this you can pick up a greater proportion of cancers, but you can also pick up a greater proportion of the more serious cancers, the more aggressive cancers. It also means that you have less anxiety in screening in the lower risk group, and it's cost effective because you focus your spend on those most likely to benefit. Now, this is in pink here is the NHS breast screening programme, and it's partly age-based and partly risk-based. But as I say, there's a publication from Manchester recently really suggesting that all women should fill out a risk questionnaire when they get to 40, and that would determine what type of screening they had going forward. And I think that has a lot to commend it. So I think we need to see this move to risk-based screening rather than age-based screening. This is our risk-stratified screening program. It starts with an online questionnaire for 6 different cancers, and it splits them for each cancer into average risk or higher risk. We've defined what higher risk means, and this allows companies to do funded screening. People at average risk, we encourage to accept NHS screening when they get to the age where they're eligible. But what we do for everybody, all participants, regardless of risk, is point them to an online education hub where we can teach people about the risk factors. We can highlight which risk factors are driving higher risk if that's where they are. And in that way, we can educate people. Signs and symptoms of breast cancer so that they do come and get seen early. And I think most importantly, we have a large medical advisory board. We have experts in all of the 6 cancers that we deal with, because the most difficult cases are when you get equivocal results. If you have some indeterminate lung nodules on your CT scan that you've had for lung screening, those are difficult conversations, and you need someone that really knows what they're talking about to help explain how they can manage that going forward. Thankfully, for most people, it's very straightforward, but there are always some people who need that extra bit of help, and I think it's really important to have that expert medical advice. So, other things to think about when developing a workplace cancer strategy is that not all employees have private medical insurance, and that's really important. We have to think about the people that don't have PMI. Private medical insurance is not really in a position to invest heavily in disease prevention, including cancer prevention, because they have to balance their books in the next 12 months, whereas the return on investment is over the next 5 to 10 years when you invest in screening. And we need whole of workforce solutions, and I think this is a particularly good example of that. So risk assessment for all participants, education for everybody, targeted screening for those at higher risk. And we're just going to introduce a kind of cancer lifestyle risk score, which will allow people to measure their score and then to try and increase that score by amending their lifestyle going forward. So this is the cancer impact calculator, which looks at a number of different things, including medical costs, mortality, death benefits, a whole range of things, and allows us to look at return on investment for companies that invest in cancer screening. And we can produce graphs like this, and you can see, based on these input variables on the left, we can see where would the most benefit occur. And we can see that for this particular demographic, there would be a large ROI for lung cancer screening, followed by prostate cancer screening. So you can tailor it. You don't have to do all 6. You can see where is the greatest risk for this company. So, cancer risk assessment and screening are key components of any workplace cancer strategy. Risk assessment can actually highlight personal lifestyle risk factors that are driving that increased risk. And risk reduction strategies encourage healthy living and more exercise. So it is a whole of workforce solution, and we can help companies work through that and look at how their investment can actually produce a return on investment, not just from the lesser treatment being required, but all these other factors that you have to take into account. And so I think, in summary, investing now in cancer prevention can help contribute to employee well-being and long-term resilience in your workforce. Thank you very much.
Thank you, Gordon. I think we've got a couple of good questions have come in, and just in relation to the data itself, one of the questions is around getting access to relevant and up-to-date data and to kind of present for working age groups, as opposed to some of the data that's out there at the moment that is from more 70s, 80s cancer risk. Is your data that you've shared live current incidence rates?
Yeah, yes, it is. And you know, I think it's really important, especially as it's going up so much, you know, each day. And again, that's what we try to do in the Cancer Education Hub and My Cancer Risk, is to keep that information up to date, because I think it is really important. For I think there was I think it was last week, Cancer Research UK just produced a new report which has some really good up-to-date data, and it's accessible online. So if you do want to read any more, I would strongly encourage you. They continue to produce really good data for the UK.
Perfect. And I think there's two there that we can join together. So you'd mentioned a bit about funding. How does that work in practice? And kind of it's related to the screening work in practice. Where do employees go for screening?
Yeah.
How does the funding work?
So that's a really good question. So if you think of the 6 cancers that we screen for, bowel, breast, cervical, lung, prostate, skin, 3 of them are at-home tests. So an HPV swab for cervical screening, a FIT test for bowel cancer screening, and a finger prick blood test for prostate cancer screening. But if you need breast screening, you need to go to a clinic to have a mammogram, a clinic to have a CT scan for lung cancer screening, and you need to come for a full body examination for skin cancer screening. We can't use apps yet for skin cancer screening because you need someone who is trained to, inspect all parts of your body to see if there's anything suspicious. So half of it at home, half of it involves coming to a clinic. And then if someone has an abnormal result, we telephone them to tell them that before we send them anything and discuss the options, staying in the private sector, going back to the NHS. If the screening test is normal, then we notify people by letter. So that it works very well.
And again, another good one, obviously we're talking about in the workplace. Do employees in that questionnaire fill out about their family background, etc., to get a better return on investment in terms of their cancer risk?
We use family history very much in the My Cancer Risk questionnaire because it is important in a number of different cancers, bowel cancer, breast cancer, prostate cancer. So family history is a big part of that. And as I was saying, that the Manchester's team that have actually a big breast cancer prevention group, they've called for this breast questionnaire, and we have really good breast cancer risk questionnaires now. We've been using them for the last 30 years, and that is a good way, and it includes family history, but it also includes a lot of other things, the age you had your first child, whether you breastfed, a whole range of things that feed into your breast cancer risk.
And I suppose here an important one for organisations that have got global teams, is this just a UK offering?
Yeah, I think that's a really good question. So it's certainly in the UK, it's very easy for us to do the risk assessment and then deliver screening. Outside the UK, it's much harder to do that. And we are getting increasing interest from cancer risk assessment globally. And I think the best way to deliver that is to do the risk assessment in partnership with these global companies and make sure that those companies have access to the relevant type of screening, what we would expect to happen here, and that they can direct their own employees to that screening once we've done the risk assessment.
Yeah, perfect. There's some really good questions coming in here. I'm trying to keep up with them. I think the two here, in terms of the best place to start if you're thinking about considering screening and what level of support an organisation might give. But I suppose that tails also into the return on investment, where people changing their lifestyles can help to reduce risk. And if you've got any good examples of that, both the preventative measures in terms of scanning and the lifestyle changes as well, how they can work together.
Yeah, I think identifying risk is perhaps the easy bit. Getting people to change their behaviour is very much the hard bit. I just listened to a presentation by AXA where you can see that they're starting to get some results from getting people to improve their BMI, take a bit more exercise. I suppose the insurer that has looked most at healthier lives is Vitality. And they've got great data showing that exercise, actually greater exercise leads to better survival. And of course, there was that great presentation at ASCO, the American Society of Clinical Oncology, 2 weeks ago that showed that exercise, a proper exercise program after quite advanced bowel cancer actually improves survival more than the chemotherapy. So there's still a lot about exercise and its impact, not just on cancer incidence, but on cancer survival when you're diagnosed that can help. So it's.
Yeah, and I suppose on that, where somebody's thinking about where to start for their group of employees, where would be the best place to start in terms of that paid screening for all 6 that you offer, or one particular counsellor, or does it really depend on the demographic?
I think it depends on the demographic, you know, especially age and whether they've actually had an issue with several cancers recently that have, you know, led to high claims, and so it's very personal. And you know, I think I think each company that we talk to has a different agenda, and you have to try and find the best solution, and that just takes a bit of discussion. So I don't think there's one size fits all. I think it's very much based on what the company wants for its employees.
Yeah. And I think we've got time for our kind of last question. So I suppose a good place to land on in terms of your offering. Are there any additional cancers that you're planning to scan for other than the 6 types that we talked through on the slides?
Yeah, I think we have to remember that screening, you have to have quite a simple test that's non-invasive, where early intervention and early detection leads to better outcomes. So those are the kind of things that we need to look at. And actually, I'm not really aware of any other cancer at the moment where we have a test that would allow us to tick all of those boxes. I think we'll see different ways of doing doing cancer screening. There's an Israeli company just now that's actually been working on a test for lung cancer in urine with amazing results. And what we could find is that you maybe use that as a primary screen, because that's easy, you could do it at home. And then if that's abnormal, then you go and have your lung CT scan. So I think there's lots of ways that we can improve screening, and we should always be looking to do that if we can.
Perfect. I think that's been really useful. So if we want to give Gordon a round of applause. And just to remind everybody to rate your session on the Slido app. And also, I think now we're moving to lunch, aren't we? Yeah. And back at 2 o'clock.